Peace be upon you all. I hope you are all well and Happy New Year. May God accept our fasting and prayers, and congratulations to you all. Today, God willing, we will talk about nuclear imaging. I know that you are all radiologists and may be a bit distant from the topic of nuclear imaging. The previous topics were all related to your work, so you might have had a better understanding of things, whether we were talking about ultrasound, CT, or even MRI, or discussing X-ray or mammography. All the previous topics were somewhat close to you. Nuclear medicine, however, is now increasingly used alongside radiology with PET-CT and SPECT-CT. Many radiologists today are writing PET-CT and have engaged in this topic, so it has become more related to you. However, the basics. After the topic and the imagination of nuclear imaging are not like the basics of radiology, we will start in nuclear imaging comfortably and try to clarify everything because there are many details. If there is anything that is not understood during the discussion, I hope you will stop me, and God willing, I will clarify it, even if it requires a video or if I need to rephrase it differently. Our discussion, God willing, will be about nuclear imaging. We will talk about the gamma camera, planar imaging, SPECT imaging, PET imaging, and then we will discuss nuclear medicine, image quality, and artifacts. After that, we will cover quality in more detail. Everything is, of course, related to each other and is considered sequential, meaning we need to start together from the beginning so that all the information is organized and interconnected. If there is anything unclear while I'm explaining, please feel free to stop and ask, or we can continue. The topic of nuclear imaging may be a bit distant from radiology, or the techniques may be somewhat different. So we will take our time as we proceed, God willing. When we talk about radionuclear imaging or nuclear imaging, what is the main idea in nuclear imaging? What is the basic idea of nuclear imaging? The main idea is that I have a technique that I use in imaging, in the process of imaging, and at the same time, I can also use it as treatment. But we will talk now about imaging. In all the previous topics, we discussed X-ray, ultrasound, CT, and MRI. We find that we perform imaging to differentiate between the various tissues in our bodies by working on certain principles. For example, we deal with the fact that there is a difference in absorption or in the attenuation coefficient between different materials. Bone absorbs X-rays at a different percentage than the surrounding tissues, allowing differentiation between the various tissues based on their ability to absorb radiation. In ultrasound, the topic is based on the idea of reflection, ultrasound properties, and the interactions that will occur between different tissues. According to the reflected signal, you will get an idea of how its shape looks and how its intensity is. You start to make differentiations between the various organs according to the reflected intensity or the echo that comes to you. MRI works on something related to the magnetic properties of tissues, whether it's T1 constant or T2 constant, the proton density, and the number of protons in different tissues in our bodies. Not all tissues undergo T1 relaxation at the same time, or their T1 constants are different, or their T2 constants are different, and the number of protons in different tissues is not constant. Therefore, I can work with this and differentiate between various conditions using the technique. You also want to reach a point where you can perform imaging, whether in CT, MRI, or ultrasound. You are primarily focused on seeing pathology or anatomy, looking for anatomy in a specific way, searching for pathology in a specific way, such as a tumor present in certain tissues or metastasis, or a specific appearance of the bone. So you are primarily leaning towards anatomy. When you are heading towards pathology, that's one thing, but in radionuclide imaging, you are leaning more towards physiology or function, focusing on functional diagnosis. For example, if you want to see the thyroid, you want to perform nuclear imaging to check how the thyroid is functioning. Is it within the normal range or the abnormal range? So you are looking at the function of the thyroid, which means you are heading towards radionuclide imaging or nuclear medicine. If you want to assess the efficiency of the heart muscle, then you are looking at cardiac imaging to see the fraction of the heart muscle. So you are heading towards wanting to see what you are capturing in volume. You want to see the range of emotions in the myocardial reality. If there are existing risks, you want to see the range of emotions in the myocardial reality. We will discuss this topic in detail, but you are moving towards physiology and the interactions of cellular cells. If you are talking about such as, for example, positron emission tomography computed, tomography, PET-CT, it's essentially the same idea. You inject a radioactive material into the body systemically administered intravenously in this procedure, which is FDG, fluorodeoxyglucose, and then subsequently start to see, clearly observe visually through imaging techniques, the accumulation of this particular material specifically within tumor cells compared to normal healthy cells.
In this video, so can you imagine, what is the shape in front of us? The view in front of us, here is the CT, computed tomography image. So you can see the anatomy in the SPECT, single photon emission computed tomography, or the physiology. The techniques are now available. SPECT and CT create a fusion between the CT image and the SPECT image. We will discuss this in detail. I want to give the patient an idea of the topic, or what exactly is happening. When I have patients, I inject them with a radiopharmaceutical and start observing them in the view. There are two heads, like the ones you see here. You see one head here, and another head. This is the view for the patient, and this is the patient on the table. What is this? This is the view from the gamma camera or SPECT. We will understand what a gamma camera and SPECT mean shortly, but this is the view I use for imaging. The whole idea is that I get a patient who wants to do a specific scan. This scan could be a thyroid scan, a renal scan, a cardiac scan, or a lung scan, or it could be a brain scan. Each of these scans uses a radiopharmaceutical, which consists of two parts, radio and pharmaceutical. Radio refers to the radioactive substance, which is a radioisotope. We will talk more about that shortly. The pharmaceutical part is a chemical carrier. The function is that I combine the two together. I either get my radioactive substance from the nuclear reactor, from the cyclotron, or from my own radiopharmaceutical generator that I have in the lab. We will discuss this more shortly. A radiopharmaceutical preparation worker brings the radioactive substance and labels it with a chemical compound, which I refer to as my pharmaceutical. The role of this chemical is to create an engagement that binds the radioactive material, acting as a carrier to the organ I want to image. For example, if I want to image the heart, I will take the radioactive substance and direct it to the heart. If I want to image the kidney, I will take the radioactive substance and direct it to the kidney. If I want to image the thyroid, I will direct it to the thyroid. This carrier has specific properties that allow it to move in the bloodstream and target the organ I want to image. Therefore, the same radionuclide, the same radioactive material can be used but with different chemical properties. Hence, it is called a radiopharmaceutical. You will find that it can be used in cases such as technetium-99 mace. There is a substance called technetium that I use. I refer to it as technetium. This is the radioactive element that binds with a chemical compound to connect the two and is injected into the patient. There are specific procedures for the cardiac scan, renal scan, and thyroid scan, each with its own requirements for the patient, such as whether to stop medication or drink water. Even the imaging itself is performed differently. The acquisition process occurs after I inject the patient, and the patient is prepared for the imaging process. The patient lies on the table or couch, and here I have the head. What is this head? This is the head that I use for detection. What am I detecting? I am detecting the gamma photons emitted from the patient. When I inject the patient with the radiopharmaceutical, this substance emits a type of radiation called gamma, which can be detected from the patient's body and reaches this head. What we are seeing is that when the head reaches a certain point, detection occurs. Once detection happens, at that moment, you can use a specific mechanism that we will discuss shortly to localize where the gamma photon is coming from. Then, it starts to give you an image. From this image, you can see a diagnosis or assess the function of the organ you are scanning. Let's take a look together. I have injected the patient now. With my radioactive substance, of course, some examinations will tell you to wait half an hour or an hour depending on the type of examination. Some examinations are performed on the table itself, like the renal scan, which moves through the body. Here is our radioactive substance or the radiopharmaceutical, which consists of a chemical compound and the radioisotope. It will go to the different organs according to each organ, and the uptake will be, as we will see shortly in the images. It starts by providing some images like this one. For instance, here in this particular region, there exists a certain substance that is most likely present, and if we are discussing the utilization of a specific chemical substance known as technetium, MDP, which is the chemical compound that I personally use. Technetium, in conjunction with MDP, possesses a phosphate group that effectively activates areas within the bone where osteoblast cells are present. These osteoblast cells have the ability to absorb the phosphate groups that are found circulating in the blood and work diligently to build up the bone in areas where there are issues, whether it is due to metastasis or a fracture in that specific area. Now, when I proceed to inject the patient with a chemical substance known as mesoxydiphosphonate, which contains the essential phosphate group, with the radioactive substance, which is technetium, what will logically happen is that the osteoblasts will start to take up phosphate. Here you have phosphate or phosphorus, which is the MDP that comes with technetium. It will accumulate in the areas where the osteoblasts are present, resulting in bright spots appearing like hot spots or lesions. This indicates higher activity, making these areas stand out compared to the surrounding tissues. You will start to see that bright area, which suggests there is a lesion, a problem, inflammation, or whatever the diagnosis may be. This area shows higher uptake from your radiopharmaceuticals, indicating an issue with the patient, compared to the background or the surrounding tissues. You will even find that the other side does not have the same uptake. For instance, you can see this point glowing like the orange color, which can be represented in a color scale or even a grayscale. Here you have a color, and here a color. The bladder is affected by a tumor, which is evident in the examination of the bone. For example, in a test like the heart scan, there is another substance called technetium. Technetium, yes, but there is another substance called mesoxyl isobutyl isonitrile, MIBI. MIB is a carrier that takes technetium and travels through the bloodstream to reach the organ you want to image. So what do I want to image? I want to image the heart. What am I imaging in the heart? You are imaging the left ventricle, not the right ventricle. What is the left ventricle? It consists of myocytes. These myocytes are the cells of the heart muscle, which have a very high percentage of mitochondria. Why mitochondria? Because you are working with a muscle that is constantly active and needs power, it needs energy. So it gets this power and energy from the mitochondria that are present, which have a very high percentage of mitochondria. We are working with a substance called MIB, which is mesoxyl isobutyl isonitrile, linked to technetium. This substance is designed to pass through the myocytes within the heart muscle cells and create an electrostatic interaction or binding with the surface of the mitochondria. In this case, when you perform imaging, you will find that the myocardial wall lights up because all the myocardium is filled with myocytes that contain mitochondria. The radioactive substance undergoes an electrostatic interaction, meaning the injected radioactive material has a positive group, while the mitochondria have a negative charge, leading to binding between the positive and negative. This is why I refer to it as electrostatic interaction, and trapping occurs so that it does not exit the heart again. After about an hour to an hour and a half, depending on the procedure you are working on, you will see the heart illuminated in this way, particularly the left ventricle, which is the cavity you are focusing on, and this is the ventricle. The patient undergoes an important, comprehensive, and detailed medical procedure referred to as a stress and rest stress study, where they engage in running activities on a treadmill. As soon as they reach their maximum heart rate or achieve certain conditions, such as reaching a specific heart rate level or experiencing chest pain, they are administered a dose of radioactive substance. In this case, the coronary arteries may experience vasoconstriction due to various factors. If there is an occlusion or stenosis in these vital coronary arteries, which supply blood to critical areas like myocardial wall segments, including parts of left ventricle, then during testing, if any segment does not receive adequate blood supply, it will appear cold rather than hot in imaging results, indicating issues preventing proper flow from its supplying artery. The next day, without exertion involved at all whatsoever, patients will again be given another round involving rest tests along administration same type radioactive substances. Injecting the radioactive substance, now the patient will undergo a scan to visualize the part that was, look at this, I call it shortcuts. See this circle? This circle is the shortcuts that we refer to in the city and the complete axial view. This axial view of the heart is like walking from the apex of the heart to the base. You move like this, cutting through the heart from the apex to the base. The upper part is the stress study and the lower part is the rest study. You see, this part is off, this part is off, this part is off, this part is off, right? If you compare the stress with the rest, you find this part off and this part lit up. What does that mean? It means that the coronary artery supplying this area, which is the anterior wall and the septal wall, had stenosis. When we performed the rest study, this part lit up, which means that blood flow was functioning during rest, indicating that there was what they call. What does it mean that this patient is in this condition? In this case, you would say we need to perform catheterization. The idea is to do a PCI, percutaneous coronary intervention, or dilation. And the catheterization is used because it has occurred or is considered not to be the one that supplies this segment or not. Yes, it is not the way of the coronary arteries that supply this segment. This view, which I call our long axis, is like taking a coronal view of the heart muscle, showing the inferior and superior parts of the heart. The same idea applies here. You will find that part of this is off, part of it is illuminated, and part of it is off again, which is returning to normal. So, what are you seeing? You are focusing on the function, not on who is concentrating on the anatomy. You are focused on seeing the function or the physiology of the heart muscle itself. The same idea applies here. This is what I call the sagittal view. This is the stress. and this is the rest. God willing, you won't get stuck on this part. The main idea is that I'm now injecting a radiopharmaceutical that starts to enter my machine to be imaged on the gamma camera or the spectrometer. After I perform imaging, I do post-processing. And the post-processing is similar to what we do in CT, where we perform reconstruction of the case, and we can have axial, coronal, and sagittal views. The same idea applies here. If we are dealing with images like the heart, we do axial, coronal, and sagittal views, and we start to see the images in this way. We also perform filtering, smoothing, and noise removal using the same techniques or imaging procedures that are done, exactly the same methodology. Of course, as you can see, this is how we see the patient. The emotional material has already occurred in the patient's body, and the gamma photons or gamma radiation are starting to be emitted. Here, my entire interaction is with gamma. I was dealing with the CT, with mammography, and with X-ray. All my discussions were about X-ray. The X-ray is an artificial source. Here, the patient himself is emitting radiation. The patient is continuously emitting radiation until the material undergoes complete washout or decay from the patient's body. So the patient is now in a state where you can interact with them. If you remove this patient from the device will not emit anything, but the patient themselves emits gamma photons. These gamma photons will be detected by the head that is present. We will talk about the components of my head and how the detection of the emitted gamma photons occurs. Then I will see my images on my monitor, write my report, and that's the end of the matter. The same idea. In the PET scan, you inject a different pharmaceutical. Here, you are dealing with positron emission tomography, which involves a different imaging modality than the spectrometer or gamma camera. It detects another type of isotope. The one I used initially was technetium, which is used in the gamma camera or in the spectrometer. Technetium emits gamma photons at 140 kilo-electron volts. That's why, since it emits a single gamma photon at 140 kilo-electron volts, this technique is called single photon emission computed tomography. However, when we talk about the PET scan, which is positron emission tomography, you are dealing with a different isotope or radionuclide, which is currently fluorodeoxyglucose, FDG. This emits a different type of imaging modality. You are dealing with an isotope which is currently used. They produce something called beta plus decay, and we will talk about it in a little while. It gives you 2 gamma photons, which is why I didn't call this the second one. I called it a single photon. These 2 gamma photons are emitted at 180 degrees. What does that mean? We will see now in the picture. The distribution of fluorodeoxyglucose, FDG, labeled with fluorine 18, a radioactive substance with a half-life of less than 2 hours, is obtained. The patient drinks water with me, and then they undergo feeding before entering for the scan. For example, if there is a tumor, there will be high accumulation of fluorodeoxyglucose, FDG. The fluorodeoxyglucose enters the bloodstream and is burned in the blood vessels, leading to accumulation in the area with the tumor, because, as you all know, the tumor takes up a lot of glucose due to its metabolism. Look here again. See the red part? This red substance is fluorodeoxyglucose, which produces something called a positron. The positron is similar to an electron, but has a positive charge. The positron travels through the patient's body for a very short distance. When it encounters an electron, which is naturally present in the atoms around, it undergoes a process called annihilation, interacting with that electron and producing 2 gamma photons. These 2 gamma photons are emitted at 180 degrees to each other. As you can see, the positron is moving towards the electron, and you have 2 gamma photons, one moving in one direction and the other in the opposite direction. Now, we start to introduce the patient into the PET scan. This PET scan has a specific design that we will discuss later. It begins to detect the 2 gamma photons using a specific crystal and provides you with a whole body image, as you can see. This is the general idea of radionuclide imaging. Is this clear so far, doctors, or is there a problem?